And for the people who are actually going to, survive carbon monoxide poisoning, they do end up having a lot neurologic symptoms, as they call it. So you're going to see peripheral neuropathy, hearing loss, psychosis, dementia, and the older you are and the longer you're exposed, obviously you're more at risk of having these adverse outcomes. Cyanide toxicity.
As a side point,
Yeah.
a lot of the damage of carbon monoxide is less the lack of oxygen and more the damage of the actual carbon monoxide. There's this
The radicals.
dog study where they had 2 sets of dogs, and one set they exposed carbon monoxide to the dogs to a certain, I forgot whatever the level was in the blood, and all those dogs died. And the other studies, they transfused carboxyhemoglobinated blood into the dogs to the same exact level, and all those dogs survived. So it's not the lack of oxygen, it's also the lack of oxygen plus the local stress of the carbon monoxide actually causes on nerve cells and so just something else. So oxygen is only a part of it. Terrible study, but very interesting.
Yeah, well, poor dogs.
Yeah. So for cyanide toxicity, we're probably tortured with this during step 1. Binds the cyanide oxidase, inhibits oxidative phosphorylation, shifting the cell's metabolism to anaerobic metabolism. You get lactic acidosis and increased metabolic acidosis with all the hydrogen ions that are flying around. Let's see. One of so the treatment for these things used to be, basically you want to remove the cyanide from the blood. You can do these with nitrates or thiosulfates. They bind the cyanide, excrete it, make it a more stable compound. One of the more safe and now first-line treatments is the cyano kit that EMS carries and was administered to our patients. It's basically hydroxycobalamin. It's a B12 precursor and does the same thing. It has a high affinity for cyanide, makes it stable, makes it soluble, and you can excrete it in the urine. Pretty safe and used pretty widely now. You give about 70 milligrams per kilogram, about 5 grams. Typically, it's IV. You give a second dose if you aren't seeing the response that you want, and you suspect cyanide toxicity. But going back to this point that Noah was bringing up, it impacts our ability to read the lab. So the carboxyhemoglobin levels aren't accurate. We don't know what they were. Our diagnosis is more based clinically. We saw, given the history of her being found inside a burning building, the extent of her burns, soot in her mouth, all these things are pointing to cyanide toxicity and carbon dioxide toxicity.
And just a couple of quick points on
Sure.
cyanide here. Especially where you're going to see it is if there are things like burning plastic and stuff like that. You'll definitely see cyanide. I once saw a case of both carbon monoxide and cyanide of someone where the couch went on fire and there were slip covers over the couch. And that kind of burning stuff, or in fires in factories especially, you'll see it. The other thing just to mention, if you're going to use the old cyanide kit, because there's carbon monoxide poisoning there, again, you skip the nitrite and the nitrite, the amyl nitrite and the sodium nitrite, and you go right to the sodium thiosulfate. Because what the nitrites do is they make methemoglobin, but you already have all that carboxyhemoglobin. Whatever you have left, you need. Regular hemoglobin, and now you go ahead and make it into methemoglobin. You have no hemoglobin that functions, and you can actually make them die sooner. So you don't want to use those things, that part of the kit, if you have the old-fashioned kit. The best way to go is with safer, especially in this situation, the cyano kit, no matter how expensive it is.
Yeah, you bring up a good point too, because the nitrites also, methemoglobin is going to precipitate hypotension in these patients who are already hypotensive.
With their vasodilators
Did
as
you
well.
see any of the EMS squads still using the old kit? I thought everybody switched to the cyano kit.
I don't know.
I know Fizzy definitely switched. I thought all the other ambulances switched too. I don't think anybody uses the.
You might be in an environment
in New York, but maybe.
Yeah, it's true.
where they use the old kits, and you have be aware of that.
Yeah, the old kits are still out, and they're less expensive than this, so people may still be holding on to them, but they're still out there.
So going back to our case, the 34-year-old woman brought in cardiac arrest. She was intubated, she got ROS, she's on pressors, IV fluids. Let's see. So initial management. Your initial management is going to be based on advanced burn life support, which is basically ATLS plus burn care. So you have your primary survey where you're focusing on early airway management, supporting oxygenation, ventilation, IV access, fluid resuscitation, and removing debris and clothing so you can decrease the burn. Your secondary survey, obviously head-to-toe exam, you're going to focus on the type of burn. Was it chemical, electric, thermal? Was it enclosed versus open? That's going to give you an idea of like exposure to cyanide, carbon monoxide. You want to ask also about blast or explosions to lead you towards are there any internal injuries, broken bones, things that you're missing because you're distracted by the burn. So you're going to also estimate total body surface area, which is a huge part of the assessment. It's going to dictate how much fluid you want to give. We'll go over each one of these ways of doing that. You want to estimate burn depth and serial exams, especially for our patient who had these circumferential burns. She was predisposed to compartment syndrome. And then you're going to manage her fluid resuscitation and obviously monitor her response to that. In terms of her airway, you do want to be vigilant with these patients, especially if you see any signs of airway injury. The edema is going to make your airway much harder in the future. So if you get on that early, better outcome for the patient. Evidence that you can use albuterol if you hear bronchospasm but no evidence of edema. If you do see evidence of thermal injury such as cough, hoarseness, soot in the mouth, anything that makes you indicate that there's like heat in the back of the oropharynx, then you want to go ahead and intubate early. Anything greater than 7.5 tubes recommended in case these patients need a bronch, preferably an 8.0. And RSI meds, you can use sucks in the first 72 hours. After that, not really recommended because of hyperkalemia. Let's see if there's anything in there. No. So you want to characterize these burns. Like I said, huge part of how it's going to dictate how much fluids you need to give. 2 systems, first degree, second degree, third degree versus partial, superficial, and full thickness burns. Main point here is that as the burn progresses, should become less painful as you take out the nerves. The way they look, basically, so you have your partial thickness here, and your full thickness, which covers all of the layers of the dermis, covers the sebaceous glands, the hair follicles, and so estimating our total body surface area. I think we're familiar with this as well. Rule of 9 is kind of a quick and dirty way of doing it. You have upper arms 9%, anterior part of your legs 9%, the posterior part of your legs 9%, and then the full front of the torso is 18, full back is 18, perineum is 1%, and then a rule of patient's hand is about 0.5% of total body surface area. More complicated, a little bit more in-depth way of doing it is a lung router. Use this in the burn centers. Probably something that we're not going to be using in the ED and acute management, but it's more accurate. It lets you measure total body surface area for infants who have, are proportioned differently. Yeah. So, you guys still with me? I know we covered a lot of material. Fluid resuscitation is the major component of burn care. I want to spend the majority of the talk kind of dissecting this chart. I think it's really important, and hopefully we can get to memorize this and really take it home. We might go a little bit over, but I think it's worth it. Just kidding, we're not doing that. we are going to talk a little bit about the Parkland formula, resuscitation, because it is a really big, it's an important part of the fluid resuscitation. A little bit of history about the Parkland formula. It goes back, so these studies are all done in dogs, which is kind of disturbing. But, you know, we know the formula, it's online, we can search it anytime we want. But it gives you an estimate of the fluid you're going to need in the first 24 hours of resuscitation based on crystalloid fluid. Let's see. So, like I said, it was developed in the 1960s by this dude, Baxter, at Parkland Hospital. And so, quick question to the juniors. Let's see. Noah. Yeah, it's so easy for you, I bet. Why would we use like lactated ringers and plasmolite versus like normocycline and fluid resuscitation in patients?
Because they're losing like more than just sodium chloride, and so you're worried about potassium, and I guess lactated ringers also, they're like acidotic, and so you're giving them a slightly basic solution.
Yeah. Also, you want to, with these high volumes of like 6.5 liters in the first 8 hours, and then tons of fluids after that, you're worried about hyperchloremic metabolic acidosis in these patients with a normal saline. And so one of the faults of the Parkland formula is that it tends to underestimate fluid resuscitation for patients with low BMI and low severity, low total body surface area. Overestimates fluid resuscitation. The patients who have higher BMI and are more severely burned. That said, these formulaic approaches to resuscitation are thought to be the major contributor to decrease in mortality in patients with burns over the last several decades. We have different decreased incidences of renal injury, hypoperfusion, ischemia associated with that. There's other formulas out there. I won't go too much into them, and I think we'll just keep going so you're a little bit behind. So fluid resuscitation. There's also a lot of research here about what kind of fluids do you give. Do you give colloid? Do you give crystalloid? Do you give hypertonic, isotonic? Do you do a mixture of both? Like in most things in medicine, colloids are once pretty popular, given, show that they were not beneficial. Actually, Cochrane review showed that increased mortality with colloids, and now research is starting to show maybe in some patients, in some instances, it is better. So patients who have low albumin or are more advanced in their time course, colloids might show benefit. This discussion also about hypertonic versus isotonic solution. Dr. D'Souza found a meta-analysis that was comparing hypertonic versus isotonic solutions. Showed that the hypertonic solutions were better at preventing tissue edema, but there's no mortality benefit. So research is still going on. I think, as we discover more and we study this more, we're going to figure out that, there's not one answer for everyone. That these are individual patients with individual needs whose fluid resuscitation will be tailored to meet those needs. Okay, so quick pop quiz for one of our attendees, Dr. Schechter. How would you calculate the amount of fluid a patient's going to need after the first 8 hours if she weighs 68 kilograms?
Well, it's 4 cc's per kg per percent. And then
You took too long, you just look it up.
We hold it back.
Wrong answer.
it's not wrong.
Shows the attending capacity of power failure.
Nelson, you can give Dr. Schechter. Close enough. Close enough.
I don't think you're thinking it.
So going back to management of these patients, like we said, tons of inflammation going on. These patients are predisposed to ARDS, and we want to stay on top of this. So, ArtsNet, I won't belabor this too much. Again, also online, you can download it. But simple parameters are: you want to calculate the predicted body weight, set a tidal volume of 8 mLs per kg, and titrate down to get to about 6 mLs per kg. Respiratory rate should be set at their baseline, shouldn't exceed 35. And then you want to adjust tidal volume and respiratory rate to your target pH levels. Ensure that your plateau pressure doesn't exceed 30 milligrams of mercury. And for us, you know, wound management, we're going to be packaging these patients out and sending them on their way. One thing that we should know, gauze and sterile saline is our friend. We want to, you know, completely disrobe these patients, make sure all the debris and whatever is burning on them is taken off, and we want to stop the thermal injury. Non-stick gauze in sterile saline and apply everywhere. If we are going to be packaging up these patients and sending them, Silvadene or even bacitracin is appropriate, and using it liberally, and making sure that they have adequate pain control. I think morphine and opiates are the mainstay, and you know, using benzos when appropriate to help get these patients to where they need to go.
I've actually had the burn center ask us not to use Silvadene because then they can't examine it really, sort of, you can't see the burn.
Okay.
Sometimes they can't assess the thickness because the Silvadine's so thick and you can't see through it. So sometimes I'll actually say don't put any creams or anything on until they evaluate.
Just with sterile gauze.
Just
the sterile gauze.
Okay. Good to know.
And again, even just for us, patients with a very wide burn, a lot of burn, you don't want to use Silvadene because the sulfur will get absorbed. The other place you don't want to use it is on the face because it can darken the face. Bacitracin is the way to go for very big burns or for anything on the face, or if they're allergic to sulfur.
Yeah, and just a note, I mean, it's kind of a little bit more long-term care, but hopefully we have a rectal probe with these patients who are managing their temperature. They are going to get hypothermic, and you know, resuscitating them with warm fluids can help, especially if we're applying cold, wet dressings to skin that's just losing tons of heat. And so, burn centers, why do we send them there? What do they have that we don't have? It turns out that they have a lot. There's interdisciplinary teams that, you know, surgeons who are well-versed in wound care management, debridement, application of skin and pain management. Rehabilitation is going to be a huge process for these people who end up surviving, nursing personnel. So they have a ton of resources, and we should try to get them there as safely as possible. As far as wind to transfer, the list is there, but it's, I mean, semi-obvious, like pretty severe burns, anything better than greater than 10%, your extremes of age, anything that's electrical, chemical burns, inhalation burns. If there's a burn and a trauma, then we want to send them, and then any burn involving sensitive areas, the face, the hands, the joint, genitalia, we want to transfer these patients. And actually, so for this case, it was actually, yeah.
Does every burn center have a hyperbaric chamber?
No, I don't think so. I think it's only Jacoby, as far as I can tell.
I thought they have to have it to be a burn center.
Staten Island is a burn center, they don't have hyperbaric.
Staten Island has 2 monoplace chambers.
What they do?
Yeah, they're single-person chambers. They use them mostly for wound care, but they have them.
I don't know.
I thought you have to be a burn center, I thought.
That wasn't one. So I was reading through like the certification process. So it's like the American Burn Association and the American College of Surgeons who certify these facilities. And I didn't see it as one of the requirements to be a burn center.
Makes sense.
But I mean, to be honest, I don't have a great answer for that. So I actually called the transfer center and tried to ask them what the process was for transfer burn. It's actually pretty easy. They handle everything. You call them, let them know you want to transfer to a burn center. They on the back end contact people who, like a normal transfer. They'll call you back with the attending you endorse to the attending, and transportation is organized. For this case, the transfer center wasn't set up yet, and it was a little bit more complicated. There was some back and forth about, did you need to talk to the burn attending, or the ED attending, or both? Who needed to accept the patient? So there was a little bit of back and forth on our end in terms of figuring out where this patient should go and how. But yeah, so transfer center, endorse.
Just as a general, in case you're having issues with the transfer, sometimes they have issues with their phone or whatever, usually you're gonna end up talking to a burn fellow. So
Yeah.
I don't think you should ever transfer to a burn center without talking to the burn unit directly, whether it's the ED transfer or not. That's, you wanna have a conversation with the person who's ultimately gonna be responsible to take care of this patient.
Yeah.
And usually the burn fellows are fairly reasonable. Obviously, this is a once the patient's stable, it's a clear transfer. But sometimes if you're not sure, you can have conversations, you can send them pictures, they
They're really
usually
helpful.
are very reasonable. And in like patients with burns, you don't necessarily need to transfer, because a lot of burns that we transfer don't get admitted, they get evaluated and get discharged. I'll actually call Staten Island because they have a clinic in Brooklyn. And I think that's really important to our patients, right? Because you're like, oh, just follow up at Jacoby, which is 2 boroughs away. Staten Island has a burn clinic that they run, I don't remember.
It's actually on Church Avenue.
Yeah, it's very close. It's not that far away, so I'll actually will call the burn fellow at Staten Island and be like, hey, I just want to get this person in the clinic, can I facilitate
So even
that?
if you're not transferring, just to get them plugged into.
Or just have a conversation
not
like, hey,
sure.
this is the deal, do you think I need to send him now, or do you think it's okay if he follows up in your clinic?
Nice. Excellent.
So the other thing about burn centers is infection, right? So those nurses in those units are very, very good at dressing changes and things. So there's no, if you don't have somebody that needs to hyperbarics, there's no urgency to fly them out of anywhere. Your center is just as good, but it's the trained nursing personnel in these burn centers that keep, that look at the dressings, they see as a green dressing, they worry about this, they worry about pseudomonas and things. The fluid resuscitation is also very important. Part one is just the start. It's got to be urine output, especially in kids, 1 cc per kg per hour. So burn centers are great, but you don't have to rush them, to get them there. If they're not carbon monoxide poison, then you go to a chamber anyway.
Yeah. So that's pretty much it. Summarize, ABLS is going to dictate your approach to these burn victims. Early assessment and management of the airway. This idea of burn shock, be aware of it. Predisposes these patients to huge amounts of fluid loss. You can use the rule of 9s to calculate how much you need to give these patient fluids, and I think that's a very important point about monitoring their fluid response. Put a bully in and make sure you know how much they're urinating out. And,
Especially kids.
yeah. Transfer when necessary. Yeah.
The 4-drug cyanide kit, they stopped making it in 2012, I looked it up. You won't be able to get it, which is probably good, the cyanide probably works much better.
And if anybody's really interested in burns, the PEM fellows rotate at the burn center at Jacoby, and you can do an elective there. You work in the burn clinic and on the burn unit.
Because we talked about titrating to affect